Thank you so much, Lisa. Thank you for this opportunity, and I'd like to thank Kettenbach for sponsoring this program. Welcome, everyone. I hope you have all had a great day, and I want to personally thank you for taking the time to join us this evening on our topic that is airway management, your patient's right to breathe. So let's dive straight in. And conflict of interest. There are no potential conflicts of interest for me to disclose. And I want everyone to understand that in October of 2017, the ADA adopted a policy on our role in treating obstructive sleep apnea and similar disorders. And I've highlighted some things for you that are of interest. That we are encouraged to screen patients for sleep-related breathing disorders as part of a comprehensive medical and dental history. And they also emphasize that dentists are the only healthcare provider with the knowledge and expertise to provide oral appliance therapy. So it's great to know that the ADA is now recognized that our profession is part of the screening process for a sleep-related breathing disorder and is also the providers that have the knowledge and expertise to provide treatment for these patients. So a little bit about me. I graduated from University of Pittsburgh in 1982. I'm a general practitioner with an emphasis on prosthetics, implants, dental sleep medicine, and TMJ. And why do you think of dentistry as a place to practice the screening and treatment of a sleep-related breathing disorder? I think we're in the prime place to do that. Once again, the ADA made that document and recommended that policy. And what do we take great pride in? That we see our patients twice a year. We all know that the health of a dental practice is based on hygiene. Healthy hygiene equals a healthy restorative practice. So we spend lots of time making sure that our patients are seen, have a very active recall system, and our team, as well as ourselves, are the ones that can be definitely at the forefront of screening for a sleep-related breathing disorder. And the other thing is this: we take great pride in the amount of time that we spend with our patients, as well as how we communicate with our patients. So we're perfectly poised to be part of the screening process. Great article that came out in Chest. When you start to read sleep literature, it's important to understand where the study was done, if it was a European study, if it was a US study, and the N, the number of people that were involved in the study. So this was a good N at 1,506. A Berlin questionnaire is a subjective questionnaire on sleep. And of the 1,506 respondents, 26% met the criteria of being at high risk of having obstructive sleep apnea, more males than females. So if you look at an average practice, that would mean 546 patients of your current practice are at high risk of having obstructive sleep apnea. Then if you look at work by Terry Young et al., the statement is they estimate that 93% of women and 82% of men with moderate to severe sleep apnea syndrome have not been clinically diagnosed. That's a lot of people that have a potentially threatening sleep-related breathing disorder that we need to screen for and then potentially treat. Welcome, Dr. Dement. Dr. Dement, as you'll see at the top, is an MD, PhD. He is affectionately known as the father of sleep medicine. He founded the first sleep research center and first sleep lab at Stanford University. And this is a quote from Dr. Dement, that our profession has looked into the mouths of countless individuals with a sleep-related breathing disorder without knowing of the disorder. And the other great comment he makes is that many times we're the first and the only healthcare practitioner to look in the oral cavity. And when I do my presentations, and I've been very thankful to be able to do presentations throughout our great country, and the majority of people that I meet would agree with this, that most of the time, the primary care physician has never looked in the mouth of a patient. And you have to ask yourself, I wonder why that is. So let's take a look at something that's one of my favorite quotes. What the brain does not know, the eye can't see. And that is so true. I was never trained in dental school at Pitt on a sleep-related breathing disorder. I did the anesthesia rotation, and we paid attention to airway. And I think the only reason that I had any clue about airway was because of my anesthesia rotation. So what's a good example of this? Quote by William Osler, what the brain does not know, the eye can't see. I'm sure we're all familiar with the FedEx logo. And I wonder how many of you know and can see the arrow in the FedEx logo. What the brain doesn't know, the eye can't see. So every time now, if you haven't seen this before, every time you see a FedEx truck go by or you see a FedEx package arrive, now you will know and see the arrow in their logo. So it gets a little bit more complicated. Let's go to dentistry. And the question I would ask is, what do you see? And I think most of you would think, okay, so is he referring to the gingival architecture, the incisal embrasures, some wear? All of us were trained to do a very comprehensive dental exam that includes the hard and soft tissues. But I highly doubt that many of us were trained to pay attention to look at the airway of our patients. So what tonight's program is about is enlightening you to pay attention to your entire patient's being. I'm not advocating that we become physicians, because we aren't. We don't want to practice outside of our scope of practice. But what we found in our practice is when we start to pay attention to the total patient, the medications that they're on, their height, their weight, their blood pressure, and most importantly, their airway, we see dramatic changes. So what the brain doesn't know, the eye can't see. So we're focusing on, once again, the entire being. So let's talk a little bit about what sleep is. I don't want all of you to be sleep experts. You don't need to be an RPS-GT. What does that stand for? A registered polysomnographic technician. Those are the individuals that do the overnight attended sleep studies during a full-blown polysomnogram. But I think you need to know a little bit about what sleep is. And there are multiple definitions for sleep. And the reason I've selected this definition is because it's by a dear friend of mine, personal friend of mine, Dr. Gilles Levine, who has published one of the greatest books that you could ever read. And he has a great background in sleep, parafunction, and TMD. So as Gilles says, that sleep is a physiologic, and that one word there is very important, and behavioral state characterized by partial isolation from the environment. The quote-unquote sleeping brain maintains a sentinel function to awaken the organism for protection purposes. So what does that mean? So if your smoke alarm in your house goes off at 2 a.m. tomorrow morning, you have two choices to make. One, ignore the alarm and go back to sleep, and heaven forbid there's a fire and you don't respond and you don't awaken and ignore it, you would perish. The second response would be that sentinel function to awaken us. We wake up and we find that there's a fire and we vacate and we protect our lives. So Dr. Dement wrote a great book, and he also did some work, and the publication was in Sleep, a Health Imperative, that states 50 to 70 million Americans have a chronic sleep disorder that contributes to poor health. Approximately 1 in 3 Americans sleep less than 7 hours per night, and there are physiological and neurobehavioral deficits that manifest and have a progressively worse chronic conditions that ensue. It goes on to say that sleep is a highly organized physiological process, and if you disorder sleep or it's deficient, it results in ill health or death. So the purpose of this discussion in this slide is this. Sleep is very important, and sleep in the past has gotten a very, very bad reputation, that we don't really need a lot of sleep, and a lot of people think that they're heroes, that they can survive on 4 or 5 hours of sleep. And now the more and more information is coming out regarding the importance of sleep and good quality sleep. So why do we sleep? It's a great question. Well, I think that most of us that have been up late nights, we realize that the next day that we are completely fatigued. So one of the functions of sleep is to have the body recover and re-energize. The next one is biochemical refreshment. And you'll see that I have restoration and growth here. One of the big things for men right now is, how is your tea? And I'm not referring to English breakfast tea. I am referring to testosterone. And we see all the ads on TV for things such as Axiron to increase our T levels. And now we're seeing more and more come out in the literature that if you have healthy sleep, that testosterone levels are starting to come back to normal levels. So it would make sense that that would be a function of sleep. Immune function. We all know if you don't get sleep and you've been up and stressed out for days or weeks at a time, typically we end up getting sick. The next thing is memory consolidation. You have to have good sleep quality in order to facilitate the encoding of new information in the brain. And then we look at the entire psychological world of sleep and well-being, and we're looking at dreaming. That would be REM sleep. The lack of sleep presents a risk of mood alteration or depression. I think most of us would agree when you're doing your intake for your medical history that you're seeing more and more people on SSRIs and SSNRIs. And I'm not saying those medications are bad, but it seems to me that anytime that a patient goes to see a physician and claims that they have a mood disorder or they're depressed, the first thing that's done is a script is written for Zoloft, or pick one of them, Xanax, Ativan. It's now in the literature. I could quote multiple citations that once you rectify sleep and have healthy sleep, the depression goes away. So there are 4 stages of sleep. Most people have now changed it to 3, but I want you to understand that in the former era of sleep, that some thought that there were 4 stages. So let's look at what N1 is. And once again, I don't want you to be so entrenched in this that you think you need to be a registered polysomnographic technician, but I think you need to understand the information so you can have a logical discussion with a sleep physician or a sleep tech. So N1 is light sleep, 2 to 5% of the night. We all know what it's like to kind of doze off. I have some terms for it. I call it church sleep or seminar sleep. We've all been to seminars or been to church and you start to doze off and you kind of hear the drone of the speaker. That's N1 sleep. Then comes stage 2 or N2. It's the first stage of established sleep. It's 45 to 50% of the night. Your eyes are very still. The heart rate and breathing become slower. How do you know that you're in N2? Well, when they're doing a full-blown attended polysomnographic sleep study, they'll see what are called K complexes on the EEG and sleep spindles that are thought to be sleep promoting and sleep preserving factors. So you'll see sleep bruxism that occurs in N2. We'll also see apnea and hypopnea occurring in these stages, and we'll talk more about that in a minute. Let's talk about N3 sleep. So what they did is they combined stage 4 with stage 3, and now just call it N3. And that's why some people call this delta sleep, because you saw these high amplitude, very slow delta waves. This is your recovery and restorative sleep. This is when it's very difficult to awaken. So if any of you have young children and know what it's like to be on a long trip and you get home late in the evening or morning and you grab your child out of the car seat and there's like a sack of potatoes and you say to your loved one, gee, do you think they're still breathing? This is N3, that really, really deep sleep where it's very difficult to awaken the child. It's very dominant in the first third of the night's sleep, and we'll look at that. Unfortunately, N3 sleep decreases with age. And I like to look at N3 sleep as body sleep. It's reparative, recovery, restorative sleep. The more time you spend in N3, you'll see that when someone is going through sleep deprivation, you'll have growth hormone secreted during this period. You'll see the activation of the immune system. And once again, this is considered deep sleep or slow wave sleep. Then we have REM sleep, rapid eye movement, or dream sleep. It should be 20 to 25% of the night's sleep. Typically, you will see 3 to 5 cycles per night, with it lasting longer in the last third of the night. We see an increase in the cerebral activity, heart rate, blood pressure, and respiration, meaning basically the sympathetic nervous system is twice as active as when you're in the awake state. This is where you have memory consolidation and you have complete paralysis of the skeletal muscles. The only muscles that are working are the diaphragm and the eyes. Once again, this is where you have apnea and hypopnea occurring. I like to make things very simple to understand, and I call REM sleep brain sleep. So we had N3, which is the deep sleep that I consider being body sleep. And then you have REM, which is what I consider to be brain sleep. So let's look at non-REM sleep. Stages 1 to 3, which comprise 75 to 80% of the night's sleep. Let's start to look at what we call sleep architecture. So we just went through the non-REM and REM cycles. So non-REM is stages 1 through 3. REM is rapid eye movement or dream sleep. It cycles 90 to 110 minutes per cycle. A normal sleep pattern has 4 to 5 cycles throughout the night. REM is dominant in the first and last third of the night's sleep. We know if we have REM sleep deprivation, that disrupts learning. Without REM sleep, the recollection of newly learned materials is impaired. So good things for us to learn here are about our kids' sleep. And even as adults, if we don't have good quality sleep and we interrupt the non-REM and REM cycles, especially the REM, and you're trying to learn new material, that is impaired. This is called a sleep histogram. This is a snapshot of an entire night's sleep. And if you'll notice, it says a normal, in quote unquote, histogram of a young adult. And you'll notice you start in the awake phase, you go through N1, 2, 3, and in this slide we see stages 4. Go back up to 3 to 2, hit a REM cycle, then sleep stage N1, then N2, 3, 4, back up, hit another REM cycle, then stage 2, stage 3, back up, hit another REM cycle, it repeats, another REM cycle, repeats, another REM cycle. So this is what we would ideally like to see. Unfortunately, you're not going to see this all the time, and you're going to see disruptions of sleep architecture. For example, the patient that I saw today had no N3 sleep and no REM sleep. His chief complaint was excessive daytime sleepiness. So I call N3 sleep, once again, body sleep. REM sleep I call brain sleep. And that's pretty evident why he feels tired all the time. He feels kind of foggy, and he's not getting any N3 or any REM sleep. So let's talk about sleep-related breathing disorders. A sleep-related breathing disorder or sleep-disordered breathing are characterized by abnormal respirations while we sleep. So they're grouped into obstructive sleep apnea, central sleep apnea, sleep-related hypoventilation, and sleep-related hypoxemia disorder. So let's start to look at a few different definitions here. And I alluded to these earlier. We talk about apnea and hypopnea. And when I meet with my patients that are CPAP intolerant and they're seeking treatment because they can't tolerate a CPAP and they're looking for an alternative, unfortunately, I find no one has ever discussed the results of a sleep study with them. So I like to make things very easy for us all to understand. So I have props in my operatory. I have corks and I have straws. And the way I explain apnea and hypopnea to patients is this. I hold a cork up to my airway. And I say, imagine having a cork stuck in your airway for 10 seconds or longer. You wouldn't be able to breathe, correct? And then everyone shakes their head, yes. So I say, every time I use the word apnea, I want you to think of a cork in your airway. So anytime you would quit breathing for 10 seconds or longer, meaning a cork in your airway, that would be an apneic event. Then imagine breathing through a straw. You wouldn't have good flow, you'd have low flow. So anytime you breathe through a straw, for 10 seconds or longer, I want you to think of that as a hypopneic or hypopnea. So I get the patients to completely understand what it means to have an apneic event and a hypopneic event. Apnea is corks, hypopnea are straws. And this really helps the patient to completely understand what we're discussing when it comes to these complicated nomenclature that they've never been explained to before. So then we have what are called respiratory effort related arousal. And that's the key word there is the word arousal. It's a change in a sleep state, but it can't be scored on a sleep study as an apneic or hypopneic event. And I spent a lot of time in the sleep lab and got to be very close friends with the director of the sleep lab. And I had a hard time understanding this word arousal, because what I think the word arousal means is a complete awakening out of sleep. And as you can see here, that's not what it is. So if you quit breathing for 9 seconds, that can't be considered an apneic or hypopneic event. If you have low or shallow breathing for 9 seconds, that can't be considered a hypopneic event because it's less than 10 seconds, and that's the definition. But what happens on an EEG is you'll see these micro arousals that occur, and it's like the body knows that there is some type of respiratory event that's starting to happen, and it will intrude on the EEG. And a lot of these people that have these arousals will complain of excessive daytime sleepiness. Then we have UARS, upper airway resistance syndrome. Once again, they don't meet the criteria for apnea or hypopnea. They appear as rearers on the sleep study. They lack the O2 desaturations. So let's think about what individuals this might affect. Typically, it's in the younger obstructive sleep apnea patients that are typically female, accompanied by GERD, depression, bruxism, hypothyroidism, and asthma. So we've all seen with our patients during our hygiene recare appointments. Let's take a 25-year-old female that is on Zoloft, Nexium. There's anterior wear that shows signs of parafunction or bruxism, and they have cupping or pooling of their lower first and second molars. We now know that that is associated with GERD. And one of the things you want to think about for this patient is them having an upper airway resistance syndrome. So perhaps you want to screen them and do some more in-depth screening, and we'll talk about that, to see if there's a potential airway issue with these patients. So let's look at definitions. AHI, corks and straws. The average number of apneas and hypopneas per hour of sleep. RDI, it's the AHI that also includes the rearers. So those are the two definitions you're typically going to see when you start to review sleep studies. So once again, apnea hypopnea index, corks and straws, and RDI, respiratory disturbance index, AHI, plus the rearers. There's a severity criteria for obstructive sleep apnea that's based on the AHI. So you have your typical snorers. Then you have those individuals that have an apnea-hypopnea index of 5 to 15 events per hour. Those are considered to be those that have mild obstructive sleep apnea. An AHI of 16 to 29 events would be someone that would have moderate obstructive sleep apnea, and greater than 30 events per hour would be somebody that has severe obstructive sleep apnea. So what actually happens when we have obstructive sleep apnea? So we have chronic recurring episodes of corks, apnea, and straws, hypopnea, of the upper airway, and that leads to intermittent hypoxemia, hypercapnia, cortical microarousals like we just discussed, an increase in oxidative stress, and sleep fragmentation. And all of these are important mediators of cardiovascular, neurocognitive, and metabolic risk. In this study, it's quoted that 23% of women, 49% of men were found to have moderate to severe obstructive sleep apnea. So obstructive sleep apnea is independently associated with everything you see on the screen here. And if you start to look at your patient's health histories and start to put together the pieces of the puzzle, hopefully you're starting to understand the correlation between a sleep-related breathing disorder, such as obstructive sleep apnea, and all the associated comorbidities that you'll see on the screen here. So these are things that we would want to pay attention to in their medical health histories, as giving us a sign, if you will, that there might be a sleep-related breathing disorder. So I put together this one slide that shows at the top the effects on the heart, the effects on the brain with a stroke, obesity, diabetes, the snoring, the cost, erectile dysfunction, nocturia, and mood, and we could just go on and on and on with this slide. You're going to find out that pretty much there's not one end organ of the human body that isn't affected by this issue. So it's interesting that in 2016, the American College of Prosthodontists came out with this statement that due to the complexity and extensive amount of time and financial expenses involved in a prosthodontic rehab, as well as the serious health effects of untreated OSA, prosthodontists should include a mandatory screening for obstructive sleep apnea. And then, as I alluded to earlier, the ADA came out with a statement in 2017 that we're encouraged to screen our patients. So let's start to talk about snoring. Snoring does fall under the umbrella of a sleep disordered breathing issue. Normal breathing is disrupted while we sleep, leading to poor quality sleep, daytime sleepiness, cardiovascular disorders, and neurocognitive problems. So we all know what it sounds like. It's the sound of the vibration of the soft palate. It is considered to be a sign of the existence or onset of a sleep disordered breathing problem. Any noise heard during respiration while the individual is sleeping is considered an indication of a problem. Work done by Victor Hofstein. He states that snoring is the cardinal symptom of sleep apnea. And this is the funny thing. Never does a patient come to the office complaining that they snore. It's always the chief complaint of the bed partner. And once you start to treat the patients with oral appliance therapy, 70% of both the patient and bed partner report an improvement in snoring after 3 months of treatment with an oral appliance. Snoring also shows to be a risk factor for hypertension, angina, cerebral infarction. We all know snoring is all over the board. Watch late night TV, look at ads in magazines. You'll see ads for all type of different snoring appliances. One thing is this: you cannot limit snoring to obese men. I always say men snore, women purr. So I have lots of friends that have a BMI, body mass index, of less than 20, skinny fit guys that snore horrifically. So I don't want you to think it's just the obese males that have an issue with snoring. You have to evaluate the patient before you know what you're looking at. So what does the literature say? That before we treat either a snoring or a patient with obstructive sleep apnea with any appliance, we should have an assessment by a physician experienced in the field or by a sleep disorders specialist. And I aspire to that. So I'm going to make this statement. I don't treat snoring without a diagnosis, because if you don't evaluate the patient's airway, how do you know what you're treating? And I think that is very, very important for us all to understand. So I would recommend that you not treat someone for snoring unless you have a diagnosis. So let's look at typically what happens with this sleep disordered breathing. It's a continuum. We start off as a normal, happy sleeper. We then become a non-sleepy snorer, someone that is a sleepy snorer, someone that would have upper airway resistance syndrome, that would then fall into the category of someone that has obstructive sleep apnea syndrome. So what are the symptoms? Excessive daytime sleepiness, chronic snoring, gasping or choking, morning headaches. That would make sense because we have hypoxic events taking place, increased oxidative stress, fatigue, increase in automobile accidents, occupational accidents. We've seen that in multiple tragedies that have occurred with train accidents, Valdez, I mean, goes on and on and on. Depression, we've discussed that as well. Personality changes and cognitive changes as well. We see obesity, oversized neck circumference, decreased sex drive and impotence, sleep-related bruxing and GERD. But don't get stuck on the photo on your right. Remember, you cannot categorize people that are obese as being the only ones that have a sleep-related breathing disorder or the potential of having a sleep-related breathing disorder. How do you diagnose? Well, typically, it's done through an attended overnight sleep study called a polysomnogram, and the diagnosis must be made by a board-certified physician, typically in your state. And the criteria keeps changing daily almost of what the diagnosis is, whether it's an AHI greater than 5. Some insurance companies say it's an AHI greater than 15 with associated comorbidities. So it seems to be a moving target. This is what happens when you have an attended overnight polysomnogram. You have anywhere from 18 to 21 leads that are connected to you. You go to sleep with this box. They videotape you. And, oh, by the way, if you're not on your back, they encourage you to roll over and get on your back, because they know that when we're on our back, the tongue falls to the back of the throat. Thereby, the tongue is the cork in the airway, if you will. And they're always looking for worst case scenarios. The new trend is coming up with home sleep testing, which I'm very much in favor of and support. And you're seeing more and more insurance companies requesting a home sleep study to be done unless it's warranted that medically the patient would benefit from an attended overnight polysomnogram. So this is typically what we'll see. There are different types of sleep monitors. Typically, you'll see a type 3, which is the most frequently used monitor for obstructive sleep apnea. There are multiple types on the market. You'll see some different ones on the screen here. And they all measure different aspects of sleep. And here's the conclusion. PSG is not necessary for most patients with suspected sleep apnea. So now you can get a report such as we see here from sleeptest.com, where it gives us the AHI on the screen on the right, talks about oxygen desaturation index on the right, and it makes a statement here on the left that the patient may benefit from the use of a nocturnal mandibular repositioning and appliance. I always like to involve ENTs when I can. And then we get a diagnosis from a board-certified sleep physician. So now that we have a diagnosis, we can actually treat the patient. So remember, review their medical histories and their medications. Look for things that would assist you in being suspect of someone that has an undiagnosed sleep-related breathing disorder. Change your health history. Ask patients, have you ever been diagnosed with sleep apnea, had an overnight sleep study, used CPAP, morning headaches, gasp, and snoring? When I did this, I was appalled at the number of patients that told me that they'd been using CPAP for 10 years, and they loved it. And other people that had had sleep studies and they couldn't tolerate a CPAP. Remember, if you don't ask, they're not going to tell you. One of the best screeners that you could use is what's called stop bang. The S stands for do you snore? The T stands for are you tired? Excessive daytime sleepiness. The O stands for observed. Has someone observed that you stop breathing while you sleep? P is pressure. Do you have hypertension or high blood pressure? A positive response to 2 or more of these, you're at increased risk for sleep apnea. Then you can add the bang component, and the B stands for a body mass index greater than 35. Age is the A. Greater than 50 is a positive response. N is neck size, 15.75 inches, and being a male is a positive response. So I like to use just the stop component because a lot of us don't have time to calculate body mass index. We can calculate their age. We should know that. Starting to measure patients' neck sizes. If you ask your hygiene team members to do that, they're going to look at you like you've fallen off your stool and hit your head. And obviously, gender, we know that from the patient. So CPAP stands for continuous positive airway pressure. It is room air. It is not oxygen. CPAP pneumatically splints the airway open. As I like to tell my patients, it blows the cork out of the airway, and it was developed in 1981. It is still considered to be the gold standard. Unfortunately, if you look at the literature, anywhere from 29 to 83% of the patients are non-adherent to CPAP therapy. And the typical term we'll hear is approximately 50% of those diagnosed with obstructive sleep apnea are non-tolerant to PAP therapy. So for the undiagnosed patient, what would be our goal? Well, to get a diagnosis, because we can't treat a patient without a diagnosis. Medicine is different than dentistry. You have to have a diagnosis before you can treat. So have your patients talk to them about stop bang. There are questionnaires they can fill out. And, you know, it's based on what therapy is best for that patient. You can look at doing a home sleep study or referring them out to a sleep physician and let them make the choice whether they have an attended overnight polysomnogram, or there are companies like sleeptest.com that send everything to the patient and they do this study in the privacy of their own home. The code for oral appliance therapy is E0486. It is for a custom fabricated device, and it is billed at the insertion date. In 2006, the American Academy of Sleep Medicine made the recommendation Then an appliance can be used to treat those with mild to moderate obstructive sleep apnea, or those patients that prefer them to CPAP, don't respond to, not appropriate candidates for, or those who fail treatment with CPAP. They updated this in 2015 and said that we should treat those patients with primary snoring, and that sleep physicians should consider oral appliances rather than no treatment for those patients with OSA who are intolerant of CPAP. So I think the biggest question is this: where in the heck do you set the bite? It's a great question. Is it 66% of maximum protrusive? Is it 50% of maximum protrusive? Is it 75%? That's where Airway Metrics comes in. Airway Metrics is the first bite registration system that was developed for dental sleep medicine. And with the Airway Metrics system, we have a snore screener at the top of your screen in the middle, and we have different bite registration keys that are in different vertical and horizontal positions, and we use this to determine where the starting position is for our appliance. Marketing and strategy. So where do you start? Where do you start with any new vertical in your practice? Let's not even talk about sleep for a second. Let's take, for an example, implants. So you want to start doing implants. How do you start? If we can all figure out the magic of whatever vertical it is you want to add to your practice, ortho, implants, sleep, where do we start? So here's what I figured out. We all have friends, family, and team members that have issues with whatever you're trying to augment your practice with. And let's take a look at adding sleep in the treatment of sleep-related breathing disorders. So here's what I'd ask you to do. Friends, family, and team. Find 5 individuals. So for me, it was my 2 buddies, Mark and Dave. We go skiing or hunting. They both snore like freight trains. Uncle Joe and Aunt Edna, you know, you're after Thanksgiving dinner. Uncle Joe falls asleep in the lazy boy, snoring like a freight train, and up goes the volume on the TV while you're watching football. And remember, it's just not men that snore, women purr. And then team members. You'll always find a team member that will say, oh my gosh, I can't sleep with my husband. It's horrific. I have to sleep in another room. So identify these 5 individuals and make these 5 individuals that you start your journey in treating a sleep-related breathing disorder. I know there were some excellent questions that came in that you shared with me. So I would love to open it up for anyone that has some questions. Is it legal for dentists to diagnose sleep apnea? And the answer, hopefully you now know, is no. It's a medical disease, and it has to be diagnosed not only by a physician, it has to be a board-certified sleep physician. If no, why are dentists able to treat sleep apnea if they can't even diagnose it? Well, hopefully I answered that for you, and that was part of the ADA's policy that came out October 23 of 2017. And, you know, if somebody is PAP intolerant, what are we supposed to do? I mean, it's part of the mandate that came out by the American Academy of Sleep Medicine that if patients can't tolerate PAP therapy, then they should be given the option to be treated with oral appliance therapy.
The question is, how do you feel about Clear Dream sleep appliances?
It's a great question. When it comes to oral appliances, I am completely agnostic. I'm nonpartisan. there are over 150 some FDA cleared appliances that we can choose from. There's not been great evidence-based studies that compare one appliance to another. They all work. They either push the mandible forward or they pull the mandible forward to assist in keeping the airway open. So great question. Hey, Lisa, can you, I can't see a lot of these questions.
Yeah.
Do you want to read? Would you mind assisting me, please?
No. The next one is, how does this relate to pediatric dentistry?
What a great question. Thank you for asking that. The reason I paused is it's such an outstanding question. If we all became more proactive in treating the pediatric population that had an airway issue, perhaps 50 years when I'm long gone, we won't have airway issues. I'm a huge advocate of using early intervention with appliances such as Healthy Start for kids that are 3 years age and up. I always like to involve an ENT. There's a lot of literature that supports adenotonsillectomy, the class 2 patient, and the sooner we treat both, and that's why I think it's really important that you treat not only the issue with the adenoids and the tonsils, but you treat the oral airway with an appliance at an early age, and then down the road, your orthodontic treatment should be minor in its treatment. And I could go on all night about that one. Great question.
Do you ever combine an appliance with CPAP in severe apnea cases?
Absolutely. It's called combination therapy, and that's throughout the literature. The problem I have with that, and there are lots of adjunctive therapies that we can get the patients involved with, breathing exercises, which I believe in, lip taping, which I believe in, huge correlation between weight loss, myofunctional therapy. The problem that I have is this. And I had a patient in yesterday or Monday that she weighed 333 pounds. And I talked to her about weight loss, and I asked her what her chief complaint was, and she really has no desire to lose weight. And that's going to be a really tough case. Her AHI was only 15, and I kind of question that with her weight being the way it is. But we have to honor what the sleep physicians give us and provide us with treatment. And I always talk to the patients that look like they have an issue or have severe obstructive sleep apnea about the possibility of combining CPAP with oral appliance therapy. I get a lot of pushback from that because the reason they're seeing me is they don't want CPAP therapy. However, please do not ever condemn, badmouth, bash CPAP. I don't cookie cut treatment. I customize the treatment for the patient. It's a patient-centric treatment. So I always try and encourage the patients to give CPAP a try. We do the oral appliance. If they're not getting a great outcome, then we'll encourage them to add CPAP onto that, and then that's their personal preference.
Okay, next one is, how do you know if your sleep appliance treatment is effective?
Another great question. So I'm a huge advocate of using pulse oximetry. Pulse oximetry is not diagnostic. It is absolutely a great screening tool. It encourages a discussion with a patient regarding airway health. And once we get a baseline and determine that they have an issue and they're diagnosed with a sleep-related breathing disorder, then I make them an appliance, and then I start to use pulse oximetry to see how well the appliance is doing, and then I calibrate the appliance based on the objective data as well as the subjective data that I'm getting from the patient.
What is a good appliance for a patient in complete dentures and also implant-supported dentures?
Great question. In 2010, I developed a protocol for treatment of the completely edentulous patient with an oral appliance, and the answer is this. You don't want an appliance that rigidly connects the mandible to the maxilla, because if the patient tries to have any type of parafunctional movement throughout the night, then it is going to want to dislodge the sleep appliance. So I like appliances for those patients that have what I call lots of slop, meaning you have lots of room to go into parafunctional movements, meaning left and right excursion and protrusive. Thank you, everyone. Have a great night. It was my pleasure being with you.